I'm Karen Finney, and welcome to Represent Our Voice. You know, long before the COVID pandemic hit, our health and our healthcare systems have been plagued by racism and bias, resulting in massive disparities in the level of quality, affordable healthcare services that white Americans and people of color receive. So the question is, has the COVID pandemic actually led to a moment of racial reckoning in our healthcare system? And what's being done to close these gaps? Well, here to help me answer these questions and so many more are Alice Benjamin, clinical nurse specialist and family nurse practitioner, Dr. Jehan El Bayoumi, or Dr. Gigi, founding director of the Rodham Institute and professor of medicine at the George Washington University School of Medicine and Health Sciences, Dr. Jeff Gardier, board-certified clinical psychologist and associate professor of behavioral medicine, public health, and cultural competence at the Touro College of Osteopathic Medicine, and Reverend Deborah Webb, a board-eligible chaplain through the Association of Professional Chaplains with a specialty in mental health. Welcome, everyone. I want to jump right in with a kind of a provocative question, because some are saying that the COVID pandemic has kind of revealed disparities in our healthcare system, or maybe created a racial reckoning. We know that the disparities are historic. So is the American healthcare system inherently racist? And Dr. Gigi, I'm going to start with you.
The answer is absolutely yes. I mean, everything is, this country was founded on three pillars: racism, greed, and violence. And so that is embedded in every institution. Actually, there are lots of dirty secrets about the healthcare system beyond sort of Tuskegee and Henrietta Lacks that people don't realize. There's a great book called Ivy and Ebony that actually speaks about the Ivy League schools and how they were basically built by slaves, but there's so much more. I think that, there's no question that COVID, because everybody was able to kind of sit still and see the disparities in stark contrast, but actually COVID is but the latest example. I'll give you an example about Washington, D.C. We are number one per capita in HIV, cancer mortality, and end-stage kidney disease. 85% of the deaths in DC from COVID are among the African-American community. Yet, we have about a 97% insurance rate of people being insured. We're only second to Massachusetts. So if that's the case, we should be one of the healthiest, and actually we're one of the sickest cities in the country. So yes, racism is an integral part, that and issues of poverty and greed and money over people.
So Dr. Jeff, let's dive in a little bit more on this question, because we know there is racism and bias in the system, but it's not just a black and white issue, right? I mean, it is people of color, the disparities between white and people of color, but it's much more than that, right? It's socioeconomics, it's language barriers. Can you talk about some of the other factors that create these disparities in our systems?
Of course, and when we're looking at health disparities, you're right, Karen, it is very complex. It is based on racism. It is based on bias. It is based on lack of cultural sensitivity and cultural competence. But more than anything else, what we do know is that medicine, for a very long time, the development of medicine was not based on the looking at the health of all people equally. We know that implicit bias has been a very real issue. We know that that has contributed to things like, for example, the National Academy of Medicine reported that minority persons are less likely than white persons to be given appropriate cardiac care, to receive kidney dialysis or transplants, best treatments for stroke, cancer, and so on. So unless we're able to address all of these myriad issues, because they all do contribute to the disaster that we have now with our health disparities, we're not going to be able to solve that problem.
You know, Nurse Alice, you are on the front lines seeing patients. And so how does all this play out in the patients that you see and in your workplace?
I primarily work in the emergency room. So I see a lot of our brown and Black people coming in to get care when they don't have a regular healthcare provider. You know, I think there's a lot of things that play a role in what's going on with our nation's health. So part of it is, lack of access to healthcare, having lack of access of quality healthcare, being uninsured, other social determinants of health. And it basically results in more brown and black people coming into the emergency rooms needing care. And it's very heartbreaking because what I'm seeing are, I'm seeing strokes, I'm seeing heart attacks, I'm seeing people very sick with COVID-19 when, had they had the opportunity to have access to quality health care or, even insurance, that perhaps these are the things that we could have mitigated. But, there's so much, so many other issues that play a role in this. And I think that it all stems from, systematic racism when it comes to healthcare and the decisions that are made and the types of care that are offered to people.
And Reverend Webb, it's such an important point that are being made. And particularly, I want to follow up on something that Dr. Jeff said. I mean, we know that research doesn't always include African Americans the same way that it does white Americans. And so the understanding, there's certain biases that have persisted about how, for example, not cardiac care was one example, but how whether or not African Americans experience same pain levels as white Americans. And one of the examples I wanted to ask you about is someone near and dear to my heart, Serena Williams. So we know that some of these factors, when we talk about disparities, aren't just the dynamic of race, but also you think you might be at a certain socioeconomic level, and that means you're going to get the best of care, and it doesn't necessarily mean that.
No, it doesn't necessarily mean that. And I think that the factor is we are all humans. We're triune beings. We're spirit, soul, and body. And the misnomer that the higher we are on the socioeconomic ladder, it kind of mitigates the problems that we would have in receiving the health care. Then Serena's case has shown us that is not true. That is not true. And our spiritual care practitioners, and then it is our duty to speak to all of humanity and help to inform and to educate and to disseminate information about the disparities on whatever socioeconomic level we're on, not just addressing the social determinants to health, as we see with the various factors with the healthcare disparities that adds to that dynamic, but also when you are on a higher echelon, that we must, this misnomer, that's the first time I've ever heard about your skin and even your pain level, because, to me, all people that hurt, they hurt, whether you're hurt physically, whether you're hurting spiritually, because we are humans. And so I had never heard that we are felt to even experience a different pain level because of the thickness of our skin. I'm going to defer that to my wonderful friend, Dr. Gigi. I don't know how true that is physiologically. But I do know as humans, because as a pastor, I have to pray for and relate to people on all socioeconomic levels, because everyone have questions now. They're trying to figure it out. Why is it happening like this, and what is going on?
Right. Dr. Jeff, I want to pick up on this and talk about cultural competence for just a moment. We talk about it a little bit in terms of research, and I was citing a study that I saw in the National Academy of Sciences showed that 50% of white medical students and residents falsely believe that there are differences between Black and white patients, things like the thickness of our skin. And I've seen other studies that talk about, pain tolerance. You were talking about cardiac care. So how do we break this down and ensure that there is more cultural competence in the system, and that people understand, we experience pain and we experience, injury in very much the same ways, regardless of the color of our skin and regardless of our zip code?
Yeah, and I think it goes beyond just what they believe the pain tolerance for Black patients versus white patients. It's a suspicion that they have that perhaps a person of color, and this is what we talk about with implicit bias and cultural blind spots, that perhaps that Black patient may be trying to manipulate to get more pain medication. Perhaps this is an attempt on their part to be able to get this medication, and as we've seen in some cases, sell it on the street. So then they generalize that stereotype to all patients. So the way we begin to fight that, of course, and I know my colleagues may agree with me, is it goes right down to the training. But even before the training, who do we choose to become our nursing students, our medical students, our PA students, our nurse practitioners? What kind of blind spots do they have? When we are interviewing them, if we see that there's not just implicit but explicit bias in the statements they make, then these are people that we have to look at either re-educating and or weeding out. But the most important thing is within the educational system, make sure that we have cultural competence courses, make sure that we have health and human behavior courses, make sure that we teach them to become advocates for patients, and that they work each and every day on those implicit biases, because guess what? We all have implicit biases. It's okay to have them, but it's not okay to look at them and work on them.
So Dr. Gigi, I'm going to follow up with you on that, because I know this is something that you study and you care about and work very closely on. How do we help our medical students, people in the healthcare profession, our nurses and others, be more cognizant of their biases, and how do we help them to administer more equal care to their patients?
So I want to push back a little bit about what was said about cultural competence. I was running the internal medicine residency program for 15 years at GW. So what I would say are a couple of things. Let's remember that in terms of health outcomes, the structural and social determinants of health account for 80% of health outcomes and why we live as long as we live. For example, in Washington, D.C., one of the 8 wards, only 42% of kids graduate from high school. If all I did was got them to graduate from high school, I would add 10 years of life, and that's just education. Mm-hmm. So going to your question about training, so I would submit to you that people go into the healthcare field for all the right reasons. But what happens is that we, the healthcare system, the training programs, actually teach racism. And let me give you an example. If we have 2 women both coming in with pneumonia, one is a college professor, the other one is a homeless woman whose HIV is in the middle of a psychotic episode, who is easier to take care of? Well, it's obvious, the woman who's got the resources. She, we tell her take the antibiotic with food, or it has to be refrigerated. If there's problems, call us back. But what happens in terms of the system is that homeless woman, first of all, she's looked at as a burden because the hospital administration is saying, get her out, get her out, get her out. We only have 1 shelter in the whole of DC that takes care of patients who are ill. Then you have, she may be psychotic, so it's hard to take care of somebody when they're spitting at you, biting you, etc. And so the case management isn't there. So what happens is that when people come in and see somebody like that patient, the psychotic homeless woman, then it's like all patients are like that. So I think it's a complex issue. And so, yes, I think we're doing a much better job of choosing the right people. The problem is when you look at the medical student that comes in and the resident that finished, they wouldn't recognize each other because we actually in the system we jade them. So I put a lot of onus on academic institutions where there's a lot of racism.
I did want to bring it over to Reverend Webb and talk about this part, the importance of these kinds of partnerships. And maybe you could talk a little bit about the partnership that you've been engaged in with GW and as a model, potentially. If you, to Dr. Gigi's question, is it working? And is it a model that other communities should be looking at?
Absolutely. It is extremely effective. The Rodham Institute in addressing healthcare disparities, for example, in Ward 8, which is the poorest ward in Washington, D.C., it takes a village. It certainly takes a village and collaboration. And so we galvanized civic and community and religious organizations, and we came together and we went to Barry Farms annually, which was a very impoverished area. Known for a high murder rate, crime rate, and not to mention, let's talk about current even the food desert, because a lot of times when people are hungry, people go out there and they will commit crime to get some food. And so we did that and we came together in Barry Farms, and Dr. Gigi did something very wonderful. What she did was she brought some of her medical students there in relation to your question earlier. She required of them to be a part of this, that they could start looking and observing and even figuring out in their educational endeavor, how can they help to disseminate this healthcare disparity that they see in these impoverished areas. And that was wonderful because not only that, you inspired the community, you inspired these kids who only see poverty and despair. You inspired them because they saw doctors that looked like them as well as that didn't look like them. But it inspired them that I can also help. And so I think it's very, very important. It is critical if we're going to reach the community and we're going to change all of these disparities in healthcare. And I like to speak to even what Dr. Jeff said about these implicit biases. And I think many of us have been victimized by it. I know I have, even as a patient. And I thought it interesting when Dr. Jeff talked about the painkillers. I've gone in and was very ill, and I'm one, I don't like taking painkillers. But when I asked for one, they kept questioning me as if I'm going to leave out. I had to tell one, look, I'm not trying to get some pain meds to go out and sell. I'm in pain. And I don't want the higher level pain meds. You can just give me some Tylenol, 800 milligrams, but I'm in pain. And so I had to advocate for myself. But these people, Karen, who are underprivileged, impoverished, undereducated, they need advocates. And historically, the church has been that institution that can be that additional voice for the people. And I like what Dr. Martin Luther King said. He said something, even as he fought for civil rights, he said something. I wrote the quote, Karen, so I wouldn't misquote it. But when he was before the Committee for Human Rights, he said something. He said, in all the forms of inequality, injustice in healthcare is the most shocking and inhumane. It is more degrading than slums because slums are a psychological death, while inequality in health means a physical death. And that's what happens when we have healthcare disparity.
What are some of the other underlying factors that our communities need to be aware of that we can try again to help advocate from a policy standpoint to try to bring some changes to help address those underlying issues?
Oh my gosh, how much time do we have? Because I think
we got plenty of time.
there's so many things to address. And if I could just say, I think, when we're talking about racism and inequality in healthcare and all these health disparities, I think, it's multi-pronged. There's lots of things we need to look at. But I think one of the things that will help us to really get to the root of this is actually creating a healthcare workforce that's more diverse, because the healthcare workforce that we have now is not at all reflective of the patients that we're treating, especially those with chronic illnesses. And so, and I'll just say this, very often, there's maybe very few of us in the emergency room or in the ICU that are people of color, yet a majority of the people that are in our beds, Hispanic, Black, Asian. And so, I live and breathe this every day, and every day I'm going to advocate, and I'm always butting my nose into into a clinical case when I feel like there is something not being done. So the example we gave about pain medications and helping to identify things that could be implicit bias. Because if you have implicit bias, you don't know, right? These are the things that are unconsciously happening. So, very often we're having case meetings, we're talking about different cases, and I'm always throwing out solutions out there, but I'm just one person. And I think if we had a more diverse healthcare workforce, that would be one. And then also it stems to training. I think Dr. Gigi said it very well, that some of the problems that we're having, we kind of actually created those in the methods and how we train people. Some of that is because, and I'll say this, we sometimes it's well intended. So for example, if you're someone you're having chest pain and say you're overweight, Black male, I'm going to heart attack. I'm going to just jump in because I'm going to use that, kind of stereotypical information to kind of quickly come to a diagnosis and try to treat you. Well, those same quick conclusions can be wrong about certain things. And I think that's where things get muddled and people don't recognize how those rush to judgment or the information they use to make those clinical decisions can actually be harmful. It could lead to over-treating someone with maybe medication. It could lead to under-treating someone with medications or treatment. It could lead to misdiagnoses. So I think it really stems with creating a diverse healthcare workforce And then also when we train, I don't know, I think more and more schools are doing this, but having an interdisciplinary approach to when we're training healthcare professionals, because doctors don't just work with doctors, nurses don't just work with nurses, respiratory therapists don't work just with respiratory therapists. We have to learn how to work together. And I think that's another opportunity to insert diversity and creative ideas. And I think the more that we can do that, the better off we'll serve the populations that we treat.
One thing, Dr. Jeff, I wanted to just follow up on is because I always want to talk about solutions. And one of the things I thought was interesting, you had Senator Elizabeth Warren, Congresswoman Ayanna Pressley, and Congresswoman Barbara Lee just introduced legislation to establish, essentially, it would be called an anti-racism center at the Centers for Disease Control and Prevention. And the idea would be here to study a lot of these different elements that we're talking about. So, not only the sort of underlying causes, but look for, patterns and racism in the system and look for solutions. Do you think something like that, centered at the CDC, could help us finally really crack some of these tough questions in terms of these disparities?
Absolutely. I certainly believe that providing a mechanism for collecting information, for doing a meta-analysis on the data that's there, but making sure we look at the data. This is how we're able to determine, epidemiologists especially, are able to determine whether there's something wrong that is happening with regard to healthcare, or looking, at an incidence or prevalence of a particular disease. We just don't do these things off the top of our heads. They have to be part of studies. They have to be part of research. So if we want to make our system better for Black and Brown people, we have to analyze what it is that's being done with those individuals and what are the present healthcare outcomes. So I think it was a brilliant move on the part of those individuals to do that.
Dr. Gigi, I want to switch gears here a little bit because we are 10 years into the Affordable Care Act, and we know that it has reduced the number of people who without healthcare insurance. Obviously, and we'll talk about this, we need to do a lot more. But I wonder if we could talk a little bit about, we just saw President Joe Biden extended the period for open enrollment. How important is that to helping more Americans get healthcare?
So again, I'm going to say that's great. I mean, the Affordable Care Act was transformative. And if you look at specific populations and specific types of care, it's helped, for example, Latinx and African-American women get much better gynecologic services, or it's actually moved the needle on infant mortality. So clearly that needs to happen.
Well, I've done a lot of work with the American Heart Association, and while there's still a lot of work to be done, they have moved the needle a little bit. And just to throw some stats out there, only one out of every Black woman knows that she's
one out of five, I think.
Yeah, 1 out of 5 African-American women believe she's personally at risk. Only 1 out of 5, when it's actually greater than that. I think Black women are so used to taking care of other people. For many, they're taking care of the children, they're taking care of the elder parents. They're trying to have careers, they're going to school. There's so many things that the Black woman is responsible for. And then oftentimes we put ourselves last on the list. I know I have. I've definitely been guilty of that. And then add on grandkids and other things. And I think that, we need to shift the thinking to say, it is okay to take care of yourself, because if you cannot be here healthy physically, mentally, emotionally, and all those things, it's going to be very challenging for you to take care of anyone else. And, with women, it's very important that they do take the time to make an appointment to see their healthcare provider. But we've been talking a lot about access, and you mentioned the Affordable Care Act earlier. One of the main reasons people don't have healthcare insurance is because they can't afford it.
Right.
They don't have access. And for those that do have access to some form of healthcare, it's not quality healthcare, or they're hesitant in accessing the healthcare system because they've had a poor experience with a healthcare provider. And so I understand it gets very challenging. I've had several people say to me, I'd like to find a Black doctor. I'd like to find another healthcare provider who gets me. And so a lot of times that gets in the way of someone getting their preventative screening. And again, we got to encourage women, just like, to take care of themselves, just as they take care of their children, that you have to make sure that you take the time to find a healthcare provider to do these basic screenings, because these basic screenings can basically save your life. I mean, I ask people all the time, do you know what your normal blood pressure is? Have you had your glucose checked? I'm asking simple questions about their healthcare, and they don't know, but they can rattle off everyone else's stuff. They know what grandpa's taking, they know what the kids are taking. And I think there's still a lot to be done. But you also take into consideration people of colors, and women as well, when they access the healthcare system, the experiences aren't always pleasant, and that can be a deterrent from seeking further healthcare. So we kind of get into this vicious cycle of, not accessing healthcare because I have a bad experience. Well, you get sick and then you have to access it, then you have another bad experience, and it's kind of this hamster wheel that we get on. But it's so critical because a lot of heart disease, the high blood pressure, the plaque buildup, all of those things, a lot of that is preventative with proper eating, exercising, getting your screening. Sometimes you have to add medicine to the mix, but if you don't go to your healthcare provider, you don't know. So we really need to take a look at what are the barriers.
Reverend Webb, I wanted to bring you in on this and talk about the role of the Black church and the work that you've done, the work you've done in partnership with Dr. Gigi and others in the community to help people advocate for themselves and their health care, and what you're seeing and what works with helping people access those needed services.
Thank you so much. I like the first, and I'm going to address that in a moment. I like the first talk about the legislative piece that Dr. Jeff had brought up, because it reminded me of in 1985, the Heckler Report. And Secretary of Human and Health Services, and she called when she commissioned this group of African-American physicians to come together and address what she called the continuing disparity in the burden of death and illness experienced by Blacks and other minority Americans as compared with all Americans. And one of those on that commission that she put together was Dr. David Satcher, who ended up becoming the U.S. Surgeon General. And so we had the former, not to mention Congressman Louis Stokes and other physicians who were at that time the head of historically Black universities, colleges of medicine. And so we need that legislative piece. And to address what Dr. Gigi said, as a spiritual care practitioner, historically, people of color, they will share with their pastor what they won't share with their physicians. They will share with you what they won't share with their clinicians, like Dr. Jeff. I have many roles that I play. I've been a mental health advocate, even at working in St. Elizabeth's. And many times the psychologists and psychiatrists would say to me, Pastor Webb, they're telling you things they don't tell us. And so consequently, the president decided he would put together a task force, and we would all then begin on this multidisciplinary team and start doing case studies to see how we could better help these long-term patients there in St. Elizabeth.
Let's pick up this issue of telemedicine, because it is something obviously in COVID that we're seeing more and more of. I can say that in my own life, I've had many more, doctor's appointments either on the phone or on video. Is that potentially a way to long-term think about how we can address some of the disparities? I mean, is it easier? Do you find that patients, whether it's a mental health appointment or a regular kind of doctor's appointment, is it easier to just answer the phone and have a phone conversation for patients? And does that also kind of, if you're talking to someone on the phone, does that help address some of the racial disparities, because you're more likely perhaps to listen to what the patient is really telling you?
Well, to some extent, yes, because then the focus is just on the voice. But we see even with telemedicine, telepsychology, telenursing, telespirituality, that there is even a health disparity there, simply because we know that there are many African-American and Latinx homes who don't have the proper hookups, who don't have the proper bandwidth, who have outdated computers. We've seen that with the online education that our children have been getting, and that's been a problem for everyone, but especially in Black and brown homes. That being said, yes, We know that even before COVID, that telemedicine, and I'll just use that as the broader term, telemedicine was something that was being instituted. It was being used more in the urban, suburban areas and far-reaching places. People can't get to their health providers. So the telemedicine was very important, especially as you talk about video. I know in my own practice, the horse has left the barn. I know that there are so many therapists, for example, who are not going to go back to seeing patients face to face unless there's a reason to do that. You know, our nurses, our physicians, they have more of that need. For the psychologists, not so much. We're not prescribing medication, of course. So we're just focused on what we're seeing. And I believe that's the way it's going to be in the future. If it was something that started before COVID, it's going to continue. And I'm seeing more and more people of color coming in for psychological services since COVID-19. And I know my colleagues can agree with me on this, that, it's you start at 6 a.m. and you end 8, 9 o'clock, 10 o'clock at night, because people are in an upside down world. But telepsychology, video conferencing has been able to get them that face to face, not necessarily person to person, but face to face contact that they need. And it saves commuting time. You just, turn on your computer, pick up your phone, and you're there instantaneously.
I would love for people to be more better advocates for themselves. And I know it's hard, but it starts with educating ourselves about, trying the best to make better food choices. Now, I understand not everybody's going to go to Whole Greens or Trader Joe's, but I like to say, if you go to Ralph's or Publix, wherever you go, buy whatever fruits and vegetables are on sale, and that's what you're going to eat that week. But, I'd like to see more education to the public as far as preventative health. What we do in the hospital is sick care. Don't even call it health care. It's called sick care because you're sick. You're coming in. And I think if we think about that, let's focus more on the prevention and the wellness.
So Dr. Jeff, let me follow up with you. Reverend Webb talked about, and we know in communities of color, there are stigmas with regard to mental health. And it's, one of the wonderful things about the Affordable Care Act, and we're seeing across the country, is mental health, what they call parity, to make sure that you can have health insurance coverage for those appointments in the same way you go and see your regular doctor. So I'm wondering, are you seeing, does telemedicine, is it lowering perhaps the stigma among our communities of color to actually think about, picking up the phone to have a conversation specifically around mental health? Do you think it's helping break down those barriers?
Yeah, I think certainly we know that when we talk about mental illness, there's always been that stigma in many communities, but certainly I can speak about in the Black and Brown community. And a lot of that had to do, and Reverend, don't jump in yet. A lot of that had to do with our churches and mosques where, it was about you go there and get all the help you want, be able to talk about, your spirituality, which is so important. But what we've seen now is that the houses of worship, the churches and the mosques, people like Reverend Webb, working with Dr. Gigi, these are the things that are breaking down that stigma, because it's saying it's okay to not be okay. It's okay to talk about these things. And we will actually even provide you psychological services within the houses of worship, which is something that we didn't do before. And I'll end with this last point here. Our younger generations are the one that are pushing the idea, and our good nurse will tell you about this, right? Are pushing the idea about mental wellness has to be an important part of the triad of body, mind, health. That's so important.
So Nurse Alice, with that, I'm going to pose the last question to you actually about that in terms of the younger generation, if you're also seeing that and seeing maybe a change in attitude to wellness overall. That's one question. And my second question, since you are again on the front lines, you touched on this, how do we help people be better advocates for themselves? Obviously, we've got partnerships like Dr. Gigi and Reverend Webb, going to our pastors, getting the information. How do I, as a healthcare consumer, as a patient, how do I do a better job?
Okay, good. So those are great questions.
Two questions.
So let me first speak to the younger generations. They're on technology. I mean, I can tell you my kids can put something together and access a program and do all kinds of stuff. And I'm still trying to figure out how to start something. They have so adapted so well to technology. They're FaceTiming, they were doing Zoom meetings and all these type of things before we as adults started really, adopting it to do our meetings and things like this. So to be able to FaceTime or have a Zoom session with your healthcare provider, your counselor, your therapist, I think that is going to remove several barriers. And Dr. Jeff said it well, that, all you have to do is turn on your device and, call in, and then you have access to your healthcare provider. You've eliminated the commute. Some people, and as we talk about mental health, although I think that there's a little bit less stigma with mental health, you're not having to go to an office, fear of being seen and all of these things. So I definitely think that the younger generation is taking their health more into consideration. They're actually very, what I've seen is, a lot more in tune to what they're eating, their exercising, their meditation, their yoga. And so I'm like, wow, okay, that's what we're doing. But I love it. I love it because we need to do that. We definitely need to do that if we're going to swing this pendulum to get away from sick care and really focus on healthcare. Now, when it comes to being a better advocate for yourself, I know the healthcare waters can be very challenging to navigate. People are overwhelmed. Even if you have insurance, who can I see? Who's in my system? Who's not in my system? Oh my gosh, I saw this person. I got a bill. And that's, there's just so many different things. But I really think it's very important for people to make connection with a healthcare provider. Obviously, if you can find someone who's referred to you, if your friends love their doctor or their nurse practitioner, whoever, hey, check them out. But definitely get connected with someone and take the first step. Make your list of questions. I tell people all the time, I better see a sheet of paper and it better be full of questions, because when you're at home, you have all the questions in the world. Then you get in front of your provider and you forget everything.
Right.
So I encourage people to write a list of questions that they have. And then also, I think is very important. Family and community, having a supportive network, whether it's your family, your friends, the church, actually all of the above would be great. But one of the things that we haven't done historically, because it's kind of been hush-hush, is we never really like to talk about what we're going through with people. And I think with things that have changed with COVID, and I've told people this several times, let people know how you're doing, check in. Right. And even if you're not able to check in and tell someone else how you're doing because you're afraid of being judged or these type of things, check on someone, check on your friend, check on your family. And I'll say this, I have checked on several of my colleagues, doctors, nurses as well, who live alone. And they've gotten sick with COVID. And this is a very stressful time. No one wants to be a burden, quote unquote, burden to someone else. And I think that the communities that we create, the friendships that we have with one another, those can make a positive impact on our health and help us to keep each other accountable when it comes to our healthcare, and empower each other. Because I'll often talk to my girlfriends about, I went to the doctor and this is what we talked about. And they'll say, oh, well, I went and they said this and this and that. We kind of empower each other. We have this community. And so
it's such a good point, because I know among my friends, we ask each other, did you get your mammogram? Have you had your colonoscopy? And they're not things that we, always like to talk about, but the more we talk about them, the more we help each other, and build that community and build the support to take care of ourselves and know what questions to ask. I love that. The list of questions. I'm going to make sure I do that the next time I see my doctor. We have to leave it there, but thank you all for such a wonderful conversation today. It's really been a joy to be with you.